Yeah, thanks, Rita. Ladies and gentlemen, thank you for giving me the opportunity to present a case here. The idea was to not only show a life-in-the-box case, let the video run for 20 minutes, but to be interactive. And what we did now is that we recorded a case from our lab very recently, and we will stop the movie at certain points in time and ask questions. And that is, of course, your chance to participate in the course, or to at least focus your attention to my presentation. And we, of course, probably cannot change our work due to your votings, but at least we have a basis for discussion. So the title of the talk is Interactive Amulet Implantation. These are my disclosures, and this is the patient, or these are the patient characteristics. It's a 70-year-old gentleman with persistent atrial fibrillation who in the past underwent multiple AF ablations, but very uncommonly, despite this, he returned with atrial tachycardia and was still in need for anticoagulation. Besides atrial fibrillation, he suffered from controlled arterial hypertension, given a CHA2DS2-VASc factor of 2. But unfortunately, he suffered upper gastrointestinal bleeding under vitamin K antagonists. This sums up in an Hasblad score of 3. So we felt that this is an appropriate candidate for an LAA occlusion device. Besides that, he had a pacemaker for sick sinus syndrome, which was implanted many years ago. Okay, so in our lab, we don't do pre-procedural imaging. We bring the patients to the hospital and to the lab the day of admission, and we don't even do TE screening prior to the procedure. This is certainly debatable, but that's the way we do it. And so we put the patient on the table, and we start the first movie. You see the ECG on the left-hand side. He's in atrial tachycardia, rate controlled, and we start with exclusion of pericardial effusion. Before we touch the patient, because we don't want to see a rim of pericardial effusion after we did something, and then at least we know that we caused it. We start, after exclusion of thrombus in the left atrial appendage, we start the venous puncture right here, but you should focus your attention to the imaging of the left atrial appendage in echo. We see a 40-degree angulation, we see a 130-degree angulation here, and we are trying, we are measuring the left atrial appendage at different levels in order to determine the appropriate landing zone. And we are giving, certain options here. One is quite proximal. We have a lobe here, which is maybe a recessus or maybe something else. At least it causes a very wide diameter of 32 millimeters. And then we are measuring a third line in this angulation, a little more distal. And on the corresponding images, we also have two lines. One is more proximal and one is more distal here. And I would like to take this opportunity now in the still screen to let you think and to help me with the landing zone. What would you consider the ideal landing zone in this patient? Please vote now. A, B, or C. Again, there's a very proximal one, the A line. Then we have the line that includes this pouch or recessus, and the distal one, C. So 60%, 2/3 are voting for C. We'll see what happens. Thank you. Then, after getting a first idea of the left atrial appendage anatomy, we're starting the transseptal puncture. You see an SL1 sheath in place, a Rottenbraun needle looking at 5 o'clock, and then we're starting the descent in the fluoro with a long bicaval view on echo and a short axis view on echo in order to see a tenting at the interatrial septum. And this is where we stopped because we felt this might be the first chance for a transseptal stick. You can see again, you see the bicaval view right here. I think you see a nice tenting here. You see the short axis view here. Not sure about tenting, to be honest. And you see the 3D reconstruction right here, and I guess the needle is poking the interatrial septum right here. You're having a look from the left atrium to the interatrial septum, and you see the fossa ovalis right here, and this is the place where the needle pokes the interatrial septum. So again, interaction please. Are you happy with this transseptal puncture site? Yes? No, it's too cranial? No, it's too caudal? Or no, it's too anterior? Where do they count? I don't see it.
No, yeah, we don't see it. No. Now you can see it.
Now we see it. 5 seconds remaining. Oh, that's good. Okay, 1/3 is happy. That's good. 2/3 are not happy. That's not good. I want to make you happy. But 35% believe it's too cranial. Only few people think it's too caudal, and 30% think it's too anterior. Let me take this voting to explain the echo images to you. I don't know, the level of expertise probably is a little different in the room. So what we believe, or what is common sense, I think, is that the bicaval view gives you the best view to determine the craniocaudal site for a transseptal puncture. So yes, I would agree with many of you that this is a cranial puncture site. I don't know if it's too cranial, but it is definitely cranial. But in order to determine the anterior-posterior orientation of your needle, you need the short axis view, and you would need to have a nicer view to the tenting. And so if your needle is tenting towards the aorta, it's definitely too anterior, and you would need to reorient your needle in a clockwise fashion to a more posterior position. So I don't think that we are really able to determine a too anterior position, but definitely I agree with you that it's a very anterior position right here. But because we're not perfect, we said, okay, let's go, come on. We try at this position, and you see the operator, I think it was me, has a lot of trouble to get across the septum here, need a lot of push, which can occur actually in patients who underwent multiple ablations because the septum is fibrosed. But so we tried hard and finally succeeded to get across the interatrial septum. It doesn't look very elegant, I admit, but at least we achieved our goal and went across to the left side. You can see the needle here, or the sheath here in the 3D image as well. The short axis view is still poor, but at least we see the transseptal crossing site in the bicaval view, and then in a few seconds you will see that we flush the sheath, and you will see bubbles on the inside the left atrium. Of course, here you go, even without pushing air into the left atrium, you see bubbles due to flushing. And okay, so we achieved the goal to go to the left atrial side, which is one of the most challenging tasks for the beginner of this therapy. Now, I understood that a lot of people in the room were not happy with the transseptal puncture side, and probably most of you wouldn't have started there. But now that we are across and we're happy that we're in the left atrium, would you change your mind? Are you happy with this transseptal puncture position? Please vote. Yes, that's perfect. Suboptimal, but okay, works for the case. Or no, definitely not. You need to repuncture. Six seconds to go. Okay, 13%, it's perfect. Thank you very much. Most of you would stay in the left atrium and try it with this position, and a minority would repuncture. Honestly spoken, I think it's worthwhile to try again and to get a better position, because the time that you're investing into a second puncture and the risk that you're taking for a second puncture is definitely less than you take with a suboptimal puncture site, which is too cranial, maybe also too anterior, and if you're trying to cannulate the left atrial appendage. Even though you might not be very, very experienced with transseptal puncture, you should restart and try to be at least in the center of the fossa valis, or even more caudal and more posterior. That's just an advice. Personal opinion. So we did repuncture. You see an RAO view here, the descent of the needle. You see the long axis view here, very nice tenting. And the operator is, the echo guy is changing to the short axis view, and now we see the needle much better. It's really in a posterior position, posterior to the center of the fossa valis, and in the middle of the fossa valis, in the bicaval view. In the 3D echo, you really nicely see that we hit the middle of the fossa valis. And probably now, if I ask the question again, most of you would say, okay, this is much, much better, and we'll ease the procedure from that point on. Our next step in the lab is an angiography of the left atrial appendage. We're taking 2 angiographies, one in an RAO 30, 15-degree cranial position, which nicely shows you the neck of the appendage. And what we can see here now, we are dealing with probably a chicken wing anatomy, which has a very distal band of the left atrial appendage. And then we take the caudal, 20-degree caudal view, which usually shows you all the lobes, the distal lobes, and foreshortens the neck a little bit. But we feel that 2 projections in the angiographic display are very helpful for sizing. And as you can see, after calibrating the system, we are sizing, or we're measuring now the diameter of the neck. This is 18 millimeters. We're taking a more distal line right here, 17 millimeters. You don't need to memorize. I will give you the numbers again later on. And we would also do the same now in the cranial view, which is in most of the times the better view for implantation of amulet devices. Now we are measuring 22 right here, and a little more distal, not much different, is 21 millimeters. So at this point in time, we would try to think what is the ideal size of the device for this particular patient. And just to summarize the numbers, I give you, you don't need to vote now, you just need to pay attention, I give you some, a little different measurements that we took. Here you have the areocranial position, 21.3 in a proximal position. We have a little more distal, we have 19.4. In the RAO caudal view, we also have 19 millimeters. And again, down here are the echo measurements that we saw previously, very proximal 22, 26 right here, 32 with the lobe, and then in the 150 view or 130 view, 20 and 18 with the more distal line. Here is the sizing chart, just for your memory. And I give you another 2 or 3 minutes to think about it, and then we'll need to vote which device to choose. But before we do so, we are exchanging the delivery sheath. You see Dr. Chan here, my friend and colleague, and he is flushing the 14 French sheath. We are using the 14 French sheath in 99% of the cases because we feel it's easier to de-air. We are using a Amplatzer stiff wire placed in the left upper pulmonary vein. There was a long discussion yesterday in the proctor's meeting. Should we exchange via the left atrial appendage? Should we leave the wire as a pigtail wire in the left atrium, or shall we use the left upper PV? Us as EP physicians, we love the left upper pulmonary vein. It's easy to find for us, and we think it's a very safe maneuver. But there was no consensus among the so-called experts yesterday. Okay, sometimes I think this is the most difficult part of the procedure, to get the sheath through a fibroid groin and a kinked venous system. You need to pay attention that your wire stays there, not to lose the wire to the right side again. And as you can see, the sheath is delivered. It flips down to the left atrium, and now this is also very important. When you get out the dilator and the wire, you should watch for back bleed. And at this point in time, you should, I don't know your setting about general anesthesia and so forth, but when you do the transseptal stick, please pay attention to the transseptal pressure. If it's high, that's good. You will have a nice back bleed. You will not have air sucked into the system. But if it's low and the patient is snoring like hell, there's a risk that air is sucked into the left atrium via the sheath. So really pay attention to that, and maybe sometimes supplement some volume. Okay, now the sheath is over, 14 French sheath. We have all options for the device. And now we need to take the most critical decision. Which device size would you choose? Would you choose a small device, 20 millimeter, 22, 25, or 28 millimeter Amulet device for these landing zones and for the anatomy that you just saw? I have the sizing chart again, but it's a different slide, so I cannot show it to you. Let me hear. Here it is, if you want to see it once more. Is the voting ongoing?
Yeah.
Yeah, oh, there it is. Excellent. So nobody wants to have the small device, which in my opinion makes sense because the largest diameter that we measured was a little larger than 20. 22, 12%, 25 millimeters, the vast majority, 2/3, and an even larger device of 28 millimeters for 24% of the people. I think this is a nice slide for comments and discussion. In my opinion, or in my small experience, 15 to 20 cases so far with the Amulet device, is that the larger devices, starting at 25, need a little more space than the ACP device in the past. So there's more material to fit into or to squeeze into the left atrial appendage. So a massive oversizing, as we sometimes did with the ACP, can be difficult with the Amulet. So we are following the majority of, or we did follow the majority of your votings and chose the 25 millimeter device. And now prepping is now much easier. That's why I let it do Dr. Chan. He can even prep this device. And it's you just need to de-air it with the best is a 50 cc syringe in my opinion, and take some time, spend some time on proper de-airing in the water bath. We skip this part, and then this is also a critical step when you attach the device to the transseptal sheath. I love to see back bleeding, because this is the best maneuver to de-air the whole system. You see now that we are opening the valve and the three-way at the end of the system in order to have back bleed and to get all the bubbles out of our sheath and away from the left atrium. For this reason, a 14 French sheath is also better. With a 12 French sheath, sometimes, or the space for back bleeding is not large enough. Then advancing the device, you know that before pushing it out, you need to pull it back to make sure that the wire is attached. And now cannulation of the left atrial appendage. We do it with the metal ball in front of the sheath. We feel very comfortable with having the metal ball out and cannulating the left atrial appendage. Some experts yesterday suggested to take a pigtail catheter. We have very good experience with this, but of course one could argue about this. For cannulating the left atrial appendage, I love to have echo because you don't even need X-ray if you have some experience to cannulate the left atrial appendage in the echo screen because you see the metal ball so nicely. And then usually we try to align the system with the axis of the left atrial appendage. And now you see the delivery of the device. The lobe is pushed out here. After controlling the lobe's position in the echo, we are desheathing the disc, which in X-ray and in the echo seals the entrance to the left atrial appendage. So this is the first position that we obtained, and I let you have a look. It's running for a little while. We are now usually assessing the position in the echocardiogram in multiple angulations. And maybe you pay attention to the echo image right here and try to get a feeling whether you like this position or not. You see a 3D reconstruction here. And I think the most important view that we will see in a minute is the 100 or 130 view. Here we have it without the 3D reconstruction. We are checking for residual flow with color Dopplers. Obviously there is no residual flow, no gaps detected in this angulation. And now we're at 90-degree angulation. And this is the most important view, I think, the 1-5. And I would like to bring your attention to something that I saw is that the Amulet device at its anterior caudal part has a little shoulder, maybe 1 or 2 millimeters. So the lobe is not completely inside the left atrial appendage. And the same feeling, or I have the same feeling that in the X-ray, in the radiocranial, we have a little what we call shoulder of the lobe in this case. So you would need to take a decision now what to do as a next step. Looks good for me, although there is a small shoulder. Release it. Let's wait a bit. I'm not sure. Maybe we can do more imaging, maybe an angiography to see where it's sitting. Or you think, no, I don't like it. Do it again. Oh my God, you're giving me a hard time. Okay, 11% think it's good. 22 want to wait a bit and do more imaging, and 2/3 don't like the position. Yeah, we didn't like it too, although it might be okay, but we felt, let's try a little better. And so we took the same decision as you did. We watched it a little more, and we see that the shoulder there is a shoulder, and the worst thing that can happen is that it falls out after we release it. So we thought, oh, come on, that was the first attempt, let's do it again. And this is shown now in a few seconds. You have to bring your delivery sheath close to the disc and pull the cable and pull the system into the sheath, which is very easy with the Amulet device. And then we were aiming for a more distal position. You see, we're advancing, or we did advance the metal ball a little deeper into the left atrial appendage. Again, erecting it inside to align it with the axis, and then push it out at a distal position. Okay, completely different shape now. I will explain this shape to you in a minute. A lot of compression on the lobe, and no real separation of disc and lobe in this first image. Well, we look at echo. At echo, the position is definitely a little more distal here. The circumflex artery, or more than 2/3, almost the complete system is behind the circumflex artery. We're measuring the compression. It's 19. So the 25 millimeter lobe is compressed to 19 millimeters. And again, we're looking at it in different angulations. This is the 100 view now. You see it's now completely plugged into the left atrial appendage. There's no more shoulder. You see the additional lobe here, which is a retroverted lobe of the distal lobe of the left atrial appendage. And usually we're shooting angiograms at this point in time. If we like the TE position, we start to do an angiographic assessment. This is what you see here. And in this cranial view, you see that the system is really inside, and that the upper part, the cranial part, is probably protruding into this chicken wing lobe going around the corner. That's why it gives this funny shape to you. So what would you do now? Looks good. Wait a bit, not sure, imaging, or would you reposition one more time? I know it might be difficult. You want to have more images now and running TEs and more fluoro, but that's life. Okay, again, almost half of it don't think it's a good position. Okay, I'd love to discuss this with you after the talk. At 1/3 I could convince, and at least 20% are undecided. Well, maybe I can convince you with these images. We felt it's the final result. I give the comparisons to you now of the different angiograms. You see that was the RAO cranial angiogram, and you have this nice cable running here by accident, and we see that the lobe is completely behind the cable. I admit that the disc is a little bit inside the ostium of the left atrial appendage. In the caudal view, we also see that we obtained a quite distal position where we measured the landing zone at 19. So maybe a 22 device would also have been appropriate. These are the corresponding TE images. You see a good sealing of the entrance of the left atrial appendage in the 40 view. And also in the 130 view, we see a complete sealing, although the ridge to the left inferior pulmonary vein has a small step right here, which I don't know if that's clinically relevant. So we continued to look at the device, at the position. We do an extensive echocardiographic evaluation, and of course, at the end, we do a stability test by pulling the disc towards the sheath. There are several ways to do it. We do it in a pulsatile manner. Some people just pull and hold it for 1, 2, 5 minutes. I don't know which one's better. We feel this one is appropriate. And as you can see, despite pulling gently, the lobe is not changing its position, which is another criterion for us that it's stable enough. Nice 3D images, and now you will see that we release the cable in the fluoro and the 3D TE image. It looks quite nice. Now the device is free and keeps its position, and even the post-procedural cardioversion left the device in place. That's the final result. I hope I also convinced the 20% that were undetermined, and if you want to see more, please come to Frankfurt in March 7th. We have another meeting there on LA occlusion. Thank you very much.